We'd like to move into our next scientific session for the afternoon, which will be focusing on psychiatric issues and psychosis, alcohol interactions. And Dr. Wilson Compton, Deputy Director of National Institute on Drug Abuse, as one of the co-moderators, I'd like to bring him up to say a few opening remarks and bring up our first speaker.
Thank you very much, Jack, and good afternoon, everyone. It's a pleasure, and it's fitting that this session is co-chaired by researchers from the National Institute on Drug Abuse and the National Institute on Alcohol Abuse and Alcoholism, because the themes cut across the interactions of the two substances as it relates to the onset of psychosis. Now, before I introduce our speakers, I want to take just a minute to answer a question that was posed at the last question and answer session. There was a question asked about, is there anything that can be done to delay the onset of use of marijuana? And our speakers were not the prevention researchers who might have addressed that. I do want to point out that there's a whole literature on evidence-based approaches to prevention. You're welcome to contact me or other researchers about this. Ralph Hinkson and others are in the audience and could help address this as well. There are programs like Strengthening Families 10 to 14 that through multiple large-scale population and school-based approaches show an impact on reducing the onset of marijuana use. So we do have approaches that are now proven through science that can delay the onset of use of marijuana and might help reduce the impacts that our previous researchers spoke about. So this brings us to the theme this afternoon, which will be on psychosis, addiction, and alcohol interactions. And with that, I bring up our first speaker, Dr. Eden Evins, who's an associate professor of psychiatry at Harvard Medical School and Massachusetts General Hospital. Welcome.
Thank you so much. It's a pleasure to be here, and I've been asked to speak about the association between cannabis use and psychosis from clinical, epidemiologic, and neuroscience perspectives. It's a very large literature, so I'll get right into it. Science started really with multiple prospective epidemiologic studies that found a consistent association in which cannabis use precedes psychosis, independent of confounding, and different studies control for confounding in different ways, which I'll talk about, independent of intoxication effects. And the association is stronger with early age at first exposure, although this isn't always controlled for cumulative exposure. Very much stronger with frequent, particularly daily use, and with use of high-potency cannabis, and I'll show you those data. It's the stronger association when risk factors for psychosis are present, and interestingly, when the outcome is a psychotic disorder as opposed to psychotic symptoms. And the association is attenuated but not eliminated in most studies by control for familial risk, socioeconomic status, other drug use, urbanicity, and prior psychiatric symptoms. And my apologies to the authors of studies that would not fit on this slide. This is a slide that will give some idea of the breadth of the literature, really starting with one of the first studies by Andreasen and colleagues in which 50,000 Swedish conscripts were studied. They were evaluated at the age of conscription around age 18 and then followed for 15 and 25 years. And in this study, people who had used more than 50 times before age 18 had a threefold increased risk of schizophrenia 15 and 25 years later. Now, this association was attenuated to some extent in those for whom there was a 5-year period between cannabis use and their psychiatric diagnosis of schizophrenia. And you see this in study after study. In the Nemesis study, there's a threefold increase risk for psychotic symptoms and a linear trend for dose. This is one of so both of these early studies had a dose effect. The more frequently people used, and this was with, again, fairly low potency cannabis at this time, in which there's about equal parts of cannabidiol and THC, presumably. But this sort of an effect has been replicated many times, and in two recent meta-analyses found essentially the same effect, an odds twofold increased risk of schizophrenia in a fully controlled trial in regular users. And then in a more recent study, in uncontrolled odds ratios, there's a twofold increased risk for psychotic symptoms in those who had any use, a fourfold increased risk in heavy users, And interestingly, the odds were even higher when the outcome was an ICD-9 or DSM diagnosis of schizophrenia, schizophreniform disorder. I mentioned a dose effect, and just wanted to highlight two studies that really look at a dose effect, and some of the first studies that include users of high potency THC. Marty DeForti looked at 280 cases who presented for clinical treatment for first episode psychosis compared to neighborhood controls controlling for these factors, and found no difference for ever use of cannabis in terms of those who with and without first episode psychosis, but a twofold increase in more than 5 years of use, so duration of use, a sixfold increase in odds for daily use of low potency cannabis, and for daily use, and then a 6.8 odds ratio of 6.8 with any high potency THC use. So daily use and any high potency THC use were similar in terms of the odds of increasing psychosis. And this was essentially the same finding in a larger study that came out last year, in which there was no difference in first episode psychosis with ever use or with duration of use, but a similar increase in odds of first episode psychosis with daily use of low potency cannabis or any use of high potency cannabis, and then a much larger increase with daily high potency cannabis use. Now, most of these studies did not control for essentially genetic risk or familial risk, and that's where this very nice study by Giordano and colleagues comes into play, in which about 5,500 people with a hospital diagnosis of schizophrenia were matched with 5 different non-schizophrenic controls with varying degrees of relatedness, from first cousins through siblings, half-siblings, siblings, and then a statistical control for monozygotic twin relationship. And in this study, there's a very high odds of any cannabis use compared to, in schizophrenics compared to non-schizophrenics in an uncontrolled analysis, but this was cut in half by control for full siblings. So 5-fold increased risk. And then it was cut to 2-fold increased if you looked at full siblings, fully controlled analysis, and 7 years distance between the cannabis exposure and the diagnosis of schizophrenia. So, as I said, there's a large dose effect, and then it's attenuated but not eliminated by very careful control for confounding and genetic risk. So this just illustrates further the dose-response relationship. This is a graphic from the DeForti study, in which essentially use of leaf cannabis, low-potency cannabis, did not particularly increase risk of psychosis. A slight increased risk with daily use, but with high-potency cannabis, you see a much, a steep curve here for increasing frequency of exposure. And this is, again, the probability of a first episode psychosis, clinically diagnosed, adjusting for age, sex, ethnicity, education, tobacco use, etc. And this is from the meta-analysis that I mentioned, published this year, in which 10 of these epidemiologic studies were compared, in which dose was essentially linearized on a ranked scale of 1 to 10. And these are the odds of developing a psychotic outcome, symptoms or diagnosis, depending on the study, with the dose of exposure. So this is a combination of frequency and potency. So it's a pretty clear picture in my mind. So cannabis use precedes psychosis in these studies, and many are very careful that there are years between the exposure and the onset of the illness. But cannabis, but schizophrenia is a neurodevelopmental disorder. It has a prodrome characterized by nonspecific symptoms that are really, it's not clear it's going to be schizophrenia until the illness manifests. And these prodromal symptoms are present long before psychotic symptoms present or diagnostic criteria are met. So that complicates understanding of whether the cannabis use preceded psychosis, but it's not at all clear that it preceded all of the risks for schizophrenia. So I mentioned 5 years between exposure and onset in the Swedish conscript study. In the Christchurch study, cannabis use before age 18 predicted psychosis at age 21 and 25. But the converse was not true. In fact, psychosis at age 18 reduced odds of cannabis use at age 21 and 25, which makes sense when I'll show you some of the infusion studies in which people with schizophrenia, when has THC infused, their symptoms do worsen. But I think those epidemiologic studies, it's difficult to control for reverse causation because of the neurodevelopmental nature of schizophrenia. And so a different approach has been used in which the polygenic risk score for psychosis calculated from GWAS data was used to evaluate the samples. And in the Forte sample, which I've mentioned twice now, she divided her sample into quartiles essentially for the polygenic risk score for schizophrenia, and as expected found a linear relationship between the genetic risk for schizophrenia and the odds of developing psychosis, but she found no difference in the genetic load for schizophrenia between cannabis users and non-users when dividing the sample either by use or non-use or by low potency, high potency use. So in this way, in this study, genetic risk for schizophrenia did not predict cannabis use. In a study by Power and colleagues in which, again, a polygenic risk score for schizophrenia and use of cannabis was investigated, also splitting the sample by use or no use or by potency. They looked at over 2,000 healthy individuals, and they found that the polygenic risk score predicted a fraction of the variance in cannabis use. So in this study, part of the association between schizophrenia and marijuana was due to a shared genetic etiology. So this is important. This is sort of a gene-environment correlation, which I think we need to keep in mind. So cannabis use has also been associated with early onset of schizophrenia, both of prodrome, of psychotic symptoms, of negative symptoms, and of first diagnosis. This study showed earlier onset of negative symptoms of schizophrenia in users versus non-users. And this study, this looks at use versus no use by gender, in which female never users have a later onset of psychosis compared to males who use cannabis. And when split by potency of cannabis use and frequency, you see a clear dose response curve in which at the top there's those who never use cannabis, and then the risk goes down with increasing frequency. The risk goes up of early onset psychosis with increasing frequency of low potency THC cannabis and then higher potency THC cannabis. And this is, I think, is particularly important. This shows different rates of onset of psychotic disorders by age of first use of cannabis. So the earlier the cannabis was used, the earlier the psychotic disorder was manifest. And then this is just one of many, many studies which I think document what's clinically very well known, in that cannabis use, either premorbid cannabis use and certainly cannabis use after diagnosis of schizophrenia, is associated with poorer outcome. So in this study, males with schizophrenia who used versus had never used cannabis before age 18 were followed for 21 years. And those who had used cannabis had twice as long duration of their first hospital stay, 2 months versus 1, had more than twice as many hospitalizations over those 21 years, had more than twice the hospital days, had threefold the odds of more than 20 hospitalizations in those 21 years, and had greater odds of a hospital stay greater than 2 years. And in this study, they control for diagnosis of personality disorder, family socioeconomic status, IQ, marital status, urban residency, risky use of alcohol, and other drug use. So this should be fairly specific for cannabis. So the clinicians have taken this to heart and have started to use these data in clinical practice. And cannabis is considered a component cause now that interacts with other factors in the development of psychotic disorders, and as such is seen as a preventable risk factor for schizophrenia, which is important because most of the risk factors for schizophrenia are not preventable. And the idea is that prevention, early identification, and treatment of cannabis use may delay the onset of a psychotic illness in those at high risk. And this is very important because age at onset of psychosis is a very important prognostic factor. So the earlier the onset of psychosis, the worse the prognosis lifetime. And first episode programs in the United States, particularly ours at Mass General and that at Yale, now actively advise siblings of those presented with first episode schizophrenia against cannabis use. It's sort of like, I know your friends are using it and it's not fair, but you can't use it. The risk is too high. So the question really to us is what underlies this association between cannabis exposure and schizophrenia. I've only presented epidemiologic data, which are problematic in understanding causation. So just to summarize, cannabis use is very strong support that it exacerbates the symptoms of a pre-existing psychosis. That's quite clear. So treatment for these people would be very important. Cannabis use precipitates schizophrenia in those at risk. I think the data are quite strong for that. And where there's mixed support is that cannabis use is a cause or a component cause for psychotic disorder that may otherwise not have occurred. And there's not strong data for that at present, although this may differ by increasing potency. The studies that we have to date are with low potency cannabis use, with the exception of several studies out of London. So I mentioned that there are multiple risk factors for schizophrenia. Schizophrenia is truly multifactorial with many environmental exposures that increase the risk. Cannabis use is clearly only one small part. If cannabis use is doubling the risk for schizophrenia, that means maybe 2% of those who use cannabis will develop psychosis. So it becomes very important to understand who's at risk. So gene-environment interactions have long been postulated to account for this inter-individual variability in the effects of cannabis exposure, because the majority of those who use cannabis clearly do not develop schizophrenia. It's been estimated that cannabis use may increase the risk of schizophrenia twofold, accounting for anywhere from 8 to 20% of cases, though there's an estimate that it's as high as 24% for high THC cannabis in areas where its use is very common. So nicotine exposure also increases risk for psychosis. But we have interesting data for cannabis. Nicotine, when you give it to someone, does not elicit positive symptoms, negative symptoms, and cognitive dysfunction. In fact, it improves cognitive function. But in these studies, starting with people with no psychiatric illness, THC, in a very nice study by Cyril D'Souza, in two doses of IV-infused THC, increased positive symptoms, negative symptoms, and worsened cognition in the course of about the first 90 minutes. When given orally, the course is longer. This is 1 hour and 2 hours, but 10 milligrams of THC increased psychotic symptoms in healthy volunteers. Cannabidiol did nothing. Interestingly, when people were pretreated with, when healthy volunteers were pretreated with cannabidiol, it attenuated the psychotic effects of THC. So this is the effect of increasing psychotic symptoms, positive symptoms in those given THC and pretreated with placebo. And this is the increase in those given THC but pretreated with CBD. And I put this graph here really just, again, to illustrate, this is a small number of subjects, but to illustrate the variability in the psychotic symptoms that are elicited by THC administration. So this is a wide range from a score of 9 to 27 on I believe this was the PANSS, positive symptom subscale. So there's a big variation. I think this is really part of what we need to better understand. This also shows the wide variation in psychotic symptoms elicited by IV THC. This study has normal controls, healthy volunteers with no risk factors discernible at the time, and people with schizophrenia that were most of them controlled with antipsychotics, but not all, in which a proportion, so 35% of those with healthy controls, but 80% of those with schizophrenia developed psychotic symptoms with 2.5 milligrams of THC infusion, was similar with the higher dose. And of interest, and to me as a clinician, there were no beneficial effects noted in the schizophrenia group in this study. And for me, I see lots of patients using high-potency cannabis and synthetic cannabinoids, and I would like to understand this better, because in the infusion studies, we're not seeing improvement in symptoms on any dimension, including anxiety and anhedonia. So one of the places to look for who's at risk is whether there's genetic moderation of the effect of cannabis exposure on psychosis or cognition. And these data are clearly mixed. I'm just going to give two examples, but this is not the be-all and end-all. But with AKT1, this is an enzyme that inactivates glycogen synthase kinase. It's been implicated in schizophrenia. And in studies, we've seen that attentional impairment on the continuous performance task, the CPT, is greater in those with psychosis who use cannabis and had the CC variant as a common functional variant. This association was significant whether you included or not people who had used cannabis in the past 12 months, so it wasn't an acute effect. And there's no effect of AKT1 on genotype on cognition in non-psychotic controls. And then in another study, cannabis users with CC genotype had a twofold increased risk for schizophrenia compared to those with TT with the TT genotype. But this increase was sevenfold higher in those who use daily, and that's depicted here. And to one more example, effects of cannabis exposure on psychosis may be moderated by COMT. It's an enzyme that's important in cortical dopamine metabolism, and there's a common val-to-met substitution that impacts enzyme activity. And those with the val-val genotype have the highest prefrontal cortex COMT activity. In animals, if you knock out the COMT enzyme or give tolcapone, which is an inhibitor, those animals are protected against cannabinoid-associated effects on the schizophrenia-related phenotypes like pre-pulse inhibition. Now, the EPI studies are very mixed on this, but in the Dunedin cohort, Caspi and colleagues reported an association of cannabis use before age 18 with schizophreniform disorder by age 26, that it was moderated by the val-val genotype, as depicted here in this graph. And in an experimental study conducted in people with psychotic disorders, their relatives, and normal controls, those with the VAL allele who also had some evidence for psychosis liability were most sensitive to THC-induced psychotic symptoms and attentional and cognitive impairment, sort of memory and attention impairment. So we clearly see that there's an association, I'm convinced, between exposure to cannabinoids and various psychotic outcomes, including the development of schizophrenia. This association between exposure in epi studies, lab studies, and animal studies has major dose effects and potentially developmental stage of exposure effects, and a large inter-individual variability in the effect. There's evidence for some gene exposure interactions, and it seems clear that reducing exposure at critical periods has the potential to reduce incidence and severity or delay the onset of psychosis. But the precise nature of this association really needs to be better understood, particularly including who is at risk. As I mentioned, we have a 2% of cannabis users will develop psychosis if this twofold increase risk is true. So we really need to understand the effects whether high potency or synthetic cannabinoid exposure increases this risk, and to clarify the molecular neurophysiologic mechanisms underlying the effects on the adolescent brain, and to clarify the effects of cannabinoids on neurodevelopmental processes and brain structures relevant to psychotic disorders. And in those who we've defined who are at risk, are there protective factors that we can implement to make them less likely to develop psychosis? And again, the clinician in me, I want to understand if there's a physiologic basis for the observation that many with schizophrenia regularly do use cannabis with deleterious effects on their illness. So I think I'm out of time. Thank you very much.
Thank you, Dr. Evins. Our next speaker will be Dr. Alan Budney, who's a professor at the Dartmouth Geisel School of Medicine. Dr. Budney.
All righty. My task today was to talk about addiction, one of those potentially adverse effects of too much cannabis use or overuse of cannabis that we need to not forget about. So in 20 minutes or less, I hope to tell you about the phenomenology, the prevalence, the outcomes, and perhaps most importantly, the probability of this problem developing. My background is I'm a clinical researcher. You won't get a lot of neuroscience in this talk. I'm going to work from the clinical perspective and try to give you a good feel of what cannabis use disorder is like from the clinical research we've done both in the laboratory and in treatment studies. Start out with what we know for sure, really, is we know that cannabis use can develop into an addiction. And I placed addiction in quotes in italics there because the problem is we really don't define addiction very well in our field, but no matter how you define it, whether you think of it as you have to have a withdrawal syndrome, whether you think you have a clinical course of compulsive use, whether it's you can't quit, you feel like you need to quit, et cetera, desire to quit. Either way, when we study cannabis use disorder with careful diagnostic studies, we've learned that it's not qualitatively different from other substance use disorders. And that's hard for a lot of people to believe, so I want to make that point, and that's the major point I'm going to try to make today. How do we know that? Well, we have evidence from the neurobiology of the brain. We have evidence from all areas of functioning, behavioral, epidemiological, wherever. Whatever we look to for cannabis use disorder, we can find it. We can rationalize why it's occurring. We've already had a whole treatise today on the cannabinoid system in the brain. So we understand that there's a place for the exogenous cannabinoids to hit the brain at the cannabinoid receptor site. We know about the reward center in the brain. We know about the habit center beside the reward center. So we know there's a biological vulnerability there. We know from human laboratory studies that the cannabis functions as a reinforcer. People take it, they sample it, they like it, they'd like to take it again. So everything's primed. What we're going to focus on today, in my talk anyway, is to look a little bit more, what does it look like with people who meet use disorder criteria? And what's the evidence for the withdrawal syndrome that they experience? What's it like and how many people seek help for cannabis use disorder? How well do we do in helping those people? And what do the quit rates look like? What do our relapse rates look like? So we're going to start there. All right, so I got interested in this. I was a cocaine treatment researcher, and I transitioned over to the cannabis world when I looked to make a name for myself, and I started a cannabis treatment clinic. And lo and behold, when these folks came in for treatment, they reminded me very much of the cocaine patients. They did not look that different. They were complaining of withdrawal symptoms, et cetera, et cetera. I thought, well, first of all, let's just compare them, diagnostic interviews we do with the cocaine folks with the ones we do with the cannabis folks, and they looked, in the end, remarkably similar. What you have here is just some data with the DSM-3R, which had actually 9 symptom criteria, and we counted the number of criteria that the cocaine folks acknowledged or endorsed. It was 7.7, and for cannabis it was 6.3. So there was a statistical difference, but it was pretty much the same. They acknowledged and endorsed all the same symptoms across the board, a few less than the cannabis users, but pretty much by and large, yes, it looked pretty similar. Maybe a little bit less severe. And since then, that was a very tiny study and not very sophisticated. There have been over 30 international studies looking very carefully at the use disorder criteria across substances. A recent paper by Debbie Hassan and her colleagues outlines this very well. And when we look at cannabis use disorder, it always looks highly similar to other use disorders. It's unidimensional in construct. That means the criteria stick together. They acknowledge the full range of criteria that people acknowledge for other types of substance use disorders. It does seem to be a little bit less severe than cocaine, opioid disorders, and alcohol disorders. But importantly, it's the most prevalent substance use disorder behind alcohol and tobacco. Cannabis withdrawal. Some people say, hey, that's the hallmark of addiction. So is there really a withdrawal syndrome? This has been questions for years. Again, as I said, the folks coming into my clinic that were trying to quit complained of withdrawal when they tried to quit. I was surprised by that. I looked to the literature. If you dug into the archives of the literature in the 70s when we gave cannabis to patients on the inpatient unit and studied it very carefully, if you looked in the back of those papers, you could see a withdrawal syndrome. But it did not look like the opioid withdrawal syndrome, so we kind of ignored it. So since then, a whole slew of people, including my laboratory and primarily Meg Haney's laboratory in Columbia, started down the road of human withdrawal studies. A number of people have studied withdrawal in the non-human lab. And wherever we looked, again, evidence for a real cannabis withdrawal disorder. I went to my colleague John Hughes, who worked down the hall from me, and he's an international expert on tobacco withdrawal. And I said, John, how do we study this in the laboratory? And he said, well, we have to set out to prove these 5 tenets. And if you can prove these 5 things, you have yourself a true withdrawal syndrome with cannabis. And so we did that. Ryan Vandre, my graduate student then, and I really embarked upon this course of study. This is the third study that we ran. And in these studies, we just bring daily cannabis users into the clinic daily, and we take all kinds of measures, et cetera, and then we pay them to quit. And we pay them to quit, we hope to see something like this happen, an onset of withdrawal response. And what we saw is just that, and over time, the withdrawal goes back 2 to 3 weeks, it comes back to normal. And if you look at controls, there's no difference. So we saw onset and time course. That pretty much convinced us of that, because we'd seen it in some earlier studies as well. Then we looked out to prove pharmacological specificity, and to do that, we gave the same model, same paradigm of treatment. We bring people into the lab, we get their usual ratings when they're still smoking. We give them a placebo pill, they show withdrawal, and then if we give them 10 milligrams of THC 3 times a day, we suppress withdrawal a little bit. We give them 30 milligrams 3 times a day, and we can suppress withdrawal completely. So we showed some pharmacological specificity, tick that one off the checklist. The most important one clinically, and the one that's most important to me because I'm a clinical researcher, is how important is this withdrawal syndrome of clinical importance? And we figured, well, how do we test that? Well, one way to test that is to compare it to a known withdrawal syndrome of clinical importance. And we thought everybody thinks tobacco withdrawal is important. So if we can show it's comparable to that, maybe they'll believe that it's a clinically important syndrome. So we set out and did a series of laboratory studies like I just described, and we also did some survey studies. This is just an example of a survey study where you see all the different symptom criteria across the bottom, both for tobacco and cannabis, and you see the ratings from people who recently tried to quit cannabis smoking or tobacco smoking, and pretty much they lay on top of each other except for 2 symptom items, and that's appetite. One increases appetite and one decreases appetite. Other than that, a small difference in cravings, but both basically people experience cravings when they quit. So we thought pretty much that's a good index of clinical importance. Other people have shown that cannabis withdrawal is related to difficulty quitting, that people report that they use cannabis to deal with withdrawal syndromes, et cetera, et cetera. So we thought the withdrawal story was settled. So the bottom line for this first part of the talk is that cannabis use disorder is real. It's there. And when it occurs, it looks very much like the other types of substance use disorders. We know that. Well, how prevalent is it? Well, Dr. Murray up here showed you a few slides, so I don't really have to show you mine. This is that same NISARC study that she showed in the beginning of this session. About 2.9% of the adults in the U.S. seem to exhibit cannabis use disorder. They acknowledge or endorse symptoms, and there's age differences where the 18 to 29-year-olds are at highest risk. I'm going to skip that. The interesting thing that Dr. Murray didn't show you is what's the probability of having a cannabis use disorder if you are a cannabis use disorder. And this is kind of fascinating. So what's the addictive potential if you try it? This is from the NISARC study as well, and this is just showing the conditional probability of having a cannabis use disorder if you used cannabis at all in the past year. And out here in the end of the graph, that's the general population 18 and older. It's about 30%. So about 1 in 3 people who are currently smoking marijuana endorse the symptom criteria for cannabis use disorder, and it varies somewhat by age. Younger people are at higher risk. I'm going to move past that. Okay, so what do we know about the prevalence of treatment seeking for cannabis use disorder? So we established it's real, it's fairly prevalent, fairly common. What do we know about treatment admissions? Do people seek treatment? Well, this is from the TEDS data set that many of you have probably seen multiple times. If we go out to this side of the graph, we have the data from 2012. And this is the percent of total admissions that are attributable to each of the substances. So, for example, this blue bar is that 40% of all the admissions in the U.S. primary substance was alcohol. So alcohol kind of swamps everything. Opiates in 2012, about 25%. And for cannabis, it was about 18%. If you look at the 2012 data, you see that cannabis increased about 3%, opiates increased kind of dramatically, and alcohol came down a little bit. So people are seeking treatment for it at fairly high rates compared to other things. If you look at just adolescents, what do they seek treatment for? Well, when they come to treatment, everything flip-flops, and it's almost always for marijuana. 12 to 17-year-olds, over 70% of the admissions are for marijuana. All right, so persons with cannabis use disorder make up a substantial portion of our treatment admissions, so we got to deal with these folks. How well do we deal with them? How effective is treatment? Well, we talked a lot about some pharmacological possibilities already today. Do we have pharmacotherapies or medications? Well, at the moment, we have no robust findings in this area. We have lots of clues and lots of targets. We heard a lot about Pha earlier, Pha inhibitors, some possibilities there. We've seen CB1 agonists, CB1 antagonists. It looks like allosteric modulators are a target I learned about today, glutamatergic targets, etc., withdrawal targets. We have lots of possibilities. There's a lot of work going on in this area. Still no robust replicated findings, but we are working on it. Behavioral treatments, there's a whole slew of behavioral treatments that have been conducted since the 2000s or so. The primary treatments that work with other types of substance use disorders, the behavioral treatments, tend to work with the cannabis use disorders. So motivational enhancement therapies, cognitive behavioral therapies, and contingency management, which is the use of motivational incentives, all seem to work. The point of this slide is just to give you an idea of how well do they work. And so what you have here on the y-axis is the percent of participants that are abstinent in a treatment study. So these are outpatient adults coming for treatment. And the green bars show you those that get the traditional behavioral treatments. And at the end of treatment here, we can get about 30% of people abstinent. If we add incentives to the traditional treatment, we get up over 40%. If we go out over time, 12 months later, we got about the best treatment, the combination treatment, we got about 30 to 35% of people abstinent. And this was in my lab. This slide here comes from a treatment study in my lab, but it's been replicated by Kathy Carroll at Yale and Ron Cadden at UConn. So the point is that even with our best treatments, we have an efficacious treatment. It gets 30 to 45% of people perhaps doing well a year out, but we leave 55, 60% of the people behind, if not more. And that's pretty comparable to what you see with the alcohol treatment and cocaine treatment. What does the treatment for adolescents look like? I've got to go quickly, so pretty much we have a whole bunch of treatments that are efficacious, that have been tested in clinical trials. How well do they do is the real question for today's talk. And this is the same as the slide I just showed you. Here are 5 very well accepted treatments that they use in the largest multi-site trial for cannabis use disorder among teens, and this is the percent that are abstinent post-treatment, and it's under 20% for all treatments. So 80% of the kids we can't seem to get to stop using, even during the treatment period. This is a study from our group we published recently. If we add incentives, we can get some kids to quit out at the end of treatment. We get up to maybe 40 or 50%, but over time we lose the effect. So with contingency management incentives, we do better, but we still lose them over time. So we obviously need better treatments for kids to get themselves in trouble with cannabis use disorder. So in summary, with cannabis use treatment, what do we see? We haven't yet identified effective pharmacotherapies. We've got some good targets and some good possibilities. Behavioral treatments are efficacious. Access to these efficacious treatments is poor. I don't have time to talk about that, but many people do not respond. Youth response actually appears to be worse than adult response, and success in disadvantaged populations is low. I don't have data to show you on that, but perhaps something to talk about later. Much room for improvement. How do we improve? This is the kind of work I'm involved in and many others are involved in. There's, again, multiple targets there other than just pharmacotherapy targets we talked about. We can improve brain function and impulsivity. We have a trial using working memory, trying to strengthen the executive function system to fight back against impulsivity and help them make better choices. We have creative incentive systems. We're using technology. We're focusing in on treatment non-responders. Lots of things to do and lots of things that we're doing. So, cannabis use disorder. It's basically a game of probabilities. People use cannabis. Not everybody develops a problem. It looks like, at the most 30%, et cetera, of current users are developing problems. So what determines this? What determines if someone develops a problem or an addiction? Well, the things for cannabis are really no different from what I can tell than any other substance use disorder. It starts with pharmacology. It starts with the drug. And as our basic scientists told us before, dose and duration are very important. Route of administration is very important. So the more potent, the more frequent, the more effective route of administration, the more possibilities or increase the probability of developing a problem or a habit. That said, that interacts with probably the more important factors, which are biological vulnerability, whether through genetics or congenital factors. And then there's availability, access, and cost. If the drug isn't very available, you can't really develop a problem on it. The more it's available, the cheaper it is, the easier access, more likely you'll develop an addiction. Intrapersonal factors like psychosis that Eden just mentioned, other types of psychiatric illnesses, impulsivity, ADHD, et cetera, all are setting conditions for the pharmacology to interact. Environmental factors. If you look carefully at that NESARC data that Dr. Murray put up, the people with the highest rate of addiction are those in the lowest SES category, below 20,000. Poverty, other impoverished environments where there are no alternatives, where academic achievement is poor, makes you ripe for when you come in contact with cannabis, you'll develop a problem with it. Societal norms, we talked earlier a little bit, I think, with the panel with some questions. Perceived risk. If you don't perceive that the drug is potentially harmful, you're more likely to try it and try it again. And perceived risk in our new environment, and new regulatory environment, is coming down. And that's a sign that probably use disorders will go up. I'm going to skip that. So the last thing I'd like to cover is what do we know about how this changing landscape of cannabis laws and regulations will affect the risk of developing cannabis use disorders, problems with cannabis. Well, I like to say this is the new form of reefer madness out there. We have a proliferation of crazy products, different ways to smoke it, different ways to vape it, oils, shatter, glass, dabbing, all with very high potency types of marijuana. We have different ways to eat it, very attractive products, candies, sodas, gummy bears, etc. So very attractive products and packaging. We have new devices that are perhaps more efficient and take away the, quote, negative parts of marijuana use, which is the toxic smoke. So when you can vaporize marijuana through these vaping devices, I don't know if this is vaping pens, this is the Cadillac vaporizer. Vaporizing all of a sudden gives you the appearance it's a safe drug to use because you don't have any smoke. And we've all learned to be afraid of smoke with tobacco smoke. But with marijuana, the smoke is toxic, but the higher probability of problems comes from addiction, not probably from the toxins of the smoke. We have advertising. When you make products legal, people want to sell them. And now we have advertising, we have colorful packaging, we have sales, we have beautiful showcases, etc. We have expos. There are conventions in Las Vegas. Who can make the best product, make the best edible? You get awards for the newest product and the most attractive substance. So what we know is medical and recreational laws are changing the perceived risk. They're going to change the availability. They're developing new products. The new products are of higher potency. They're attractive. They have probably higher reinforcing efficacy. The delivery devices are perceived as safer, and they may be more efficient. What we're learning about vaporizers is perhaps they developed the product of choice, the THC, more efficiently and perhaps more cost effectively. There's advertising, competition, and sales, which means there's going to be more use, nudging people perhaps that wouldn't use towards use, nudging you to use more. And the product packaging and labeling is made to sell more product. Put those together, and I think what we know is we're going to increase use and increase probability of use disorder development. So overall, what do we know? Cannabis has substantial addictive potential. It's common. It resembles other substance use disorders. It may be on the increase. Interventions that we've developed to deal with those increased rates are efficacious, but there's a lot of room for improvement. Factors that influence the probability of cannabis use disorder really are in the same class and the same types of other substance use disorders. And I think we know that the changing laws and regulations will impact the development and prevalence of CUD, and probably in the wrong direction. What we still need to know is how to translate our knowledge into more effective prevention and treatment strategies, as well as dissemination strategies. And we also need to know more now than ever is how to best communicate accurate information about cannabis use and its associated risks to the public. What's the science of communication? We are not very good at that. We've lost the war to the legalization folks, but how do we communicate now that things are moving in the other direction, that there's still some risk, even if things are becoming, quote, legal? And last, we need to know how to address the changing legal and regulatory systems to minimize the impact on rates and consequences of cannabis use disorder. We really kind of need a new cannabis regulatory science, like we're going down the road of tobacco regulatory science. It's time to really look towards cannabis regulatory science. The problem we all know with science is it moves very slowly, so we need to get going. And the exciting thing about today was what we really heard is there are lots of strategies in place, movement in place to get us what we need to do the research we need to do. It's still going to take a while, but that's where the answers will come. Last, I'd just like to acknowledge support from NIDA and NIAAA and my universities and colleagues. Thank NIH for inviting me today and the folks that help contribute to the research I do. Thank you.
Thank you, Dr. Budney. Our next speaker will be Dr. Lauren Parsons, who's a professor at the Scripps Research Institute. Dr. Parsons.
Okay, I'm going to do that. Good afternoon. I would like to thank the organizers, Nora, Jack, thank you for the invitation to be here and for organizing this. It's been a wonderful meeting so far. Really some wonderful posters this afternoon. I hope people made their way around to see that. So I have been charged with addressing the idea of marijuana and alcohol interactions in 20 minutes. And so this will be a bit of a challenge. It'll be a whirlwind, but I hope it'll be interesting to you. I'm going to briefly cover some of the aspects of the comorbid use of these things, who's doing it, how much, perhaps why, and what some of the consequences might be, and then a bit of time looking at the biological mechanisms that might be underlying this and underlying some of the consequences of their combined use. So that's what we're moving forward to. Okay, so this is the... Oh, that's not working right. Yeah. I'm a Mac guy, sorry. There we go. Okay. Blame it on Apple. They're getting lots of heat otherwise, right? So this is the present distribution of drug use in the United States, at least based on most recent estimates. And this is not a big surprise. Alcohol, tobacco, and marijuana really lead the pack. In fact, more than 50% of the U.S. population indicate that they're presently using alcohol. Now, what's talked about a little bit less is polysubstance use. People aren't monotheistic in their drug use, and especially with something like alcohol, where the prevalence is so high, the likelihood is it's going to be used with other substances, and in fact, that's the case. And we know that alcohol and nicotine go hand in hand, so their use is very prevalent and not even here. But of the remaining drugs that are here, you can see what stands out is marijuana and alcohol use really is far more prevalent than the other drugs that are listed here as commonly used with alcohol. Now, if you break this down a little bit further, this is the same sort of breakdown but split apart by gender. You see the pattern is similar between women and men. Men tend to use a little more drugs than women. But then a further breakdown depending on whether the drug is used concurrently or simultaneously. And concurrent means, okay, you use alcohol and occasionally or even frequently you use cocaine, but not necessarily at the same time. Simultaneous, on the other hand, means just that, used on the same occasion. And what jumps out here is that particularly with marijuana and alcohol use, the simultaneous use is really the prevalent form of use, much more so than for the other forms of co-abuse with alcohol. And as you'll see, this will present some sort of unique characteristics. So the use of this by age follows what we see with other drugs. Adolescents and young adults tend to use more drugs and then age out of that over time. This happens as well for the concurrent and simultaneous use of alcohol and marijuana. This sort of tendency to have higher use of simultaneous alcohol and marijuana really traverses ethnic classes. It doesn't seem like it's one particular group that's driving this association. Now, there are sort of mixed reports of whether or not pharmacokinetics might be different with both drugs on board. There were some early studies suggesting that alcohol may increase plasma levels of THC and perhaps decrease the elimination of THC. Some evidence that marijuana may attenuate the rise in plasma alcohol levels. And this may sort of blunt the sedative effects of alcohol. But for every one of these studies, there's also studies that have pretty carefully looked at this analytically and not found that. So it's not entirely clear that that's the case. The likelihood is that the combined effects are produced more from altered neurobiologic responses to the drugs on board. Now, there are several sort of adverse consequences, if you will, or things that are associated with combined use of alcohol and marijuana. This includes an increase in alcohol intake, which of course would go hand in hand with alcohol dependence, increased incidence of depression, as well as social consequences. And what I mean by that here is increased interactions with the justice system, if you will, problems at work and academically, increased familial problems, etc. And what you see for most of these is that each of these sort of adverse effects are more pronounced with the simultaneous use versus the concurrent use of these drugs. Now, with regard to depression, not a big difference in terms of the form of concurrent or simultaneous use, but it is known that the combined use of alcohol and marijuana is associated with a higher rate of major depressive disorder than the use of either of these drugs on their own. And we've known for some time that alcohol dependence is strongly associated with major depressive disorder, and in fact might actually be causal in terms of forming this disorder. Now, in contrast, marijuana use is less strongly associated with major depressive disorder. Certainly individuals with the disorder will use marijuana, but the evidence suggesting marijuana leads to this is not terribly strong. So this might suggest that in this case, the presence of marijuana with alcohol may be exacerbating some biologic consequence of the alcohol intake, leading to this increased prevalence of depression in this case. Now, with regard to this increase in alcohol consumption, there are many studies indicating that combined use of alcohol and marijuana leads to an increased incidence of binge drinking, and this is especially true among college students. It's estimated that students who smoke marijuana are 6 to 7 times more likely to engage in binge drinking than others. Now, a lot of things could be contributing to this, certainly some biological factors that we'll talk about here in a minute. Also, college is a very stressful time, and both alcohol and marijuana are used for stress reduction. So particularly in this group, there may be motivation for this kind of thing. Regardless of the factors leading to this, it is known that binge drinking is a major susceptibility factor for the development of alcohol use disorders. And in fact, there is a higher prevalence of alcohol use disorders associated with the combined use of these drugs. So in support of that, here's some data from the NESARC data set that Dr. Murray brought up earlier. Data gathered in this case in 2 waves, initially in 2001, and then those same individuals were followed up on 3 to 4 years later. And it was found that of the individuals that at wave 1 did not present an alcohol use disorder, those that used marijuana were much more likely to present an alcohol use disorder 3 to 4 years later, as compared to people who also drank but didn't use marijuana. Now, the forms of alcohol use disorder may be a bit more prevalent. In this case, these are individuals who presented alcohol use disorder at wave 1. If they also used marijuana, they were more likely to still have an alcohol use disorder at the later time point as compared to those who drank but didn't smoke. So one of the questions that has come up is which is the cart and which is the horse? What might be driving things here? And that's really kind of hard to get at. There is that information regarding depression, but we're starting to see some studies now that begin to answer this. This is a study that has just come out that looked at urban youths, and it's a prospective study looking at drug use during high school and then followed these individuals up into a later age. And it turned out that in the group of individuals, you could divide up some of the subjects based on their marijuana use, but with common amounts of alcohol intake. So this is a moderate level of alcohol consumption. And the only distinguishing factor then is whether or not they used marijuana. And you can see that the proportion of the individuals that eventually developed substance use disorder was higher in the individuals who used marijuana. Now, it turns out there was another group that was sort of matched on their marijuana use but differed in terms of their alcohol use. And again, you see a stair step. And so these data suggest that it may not be one leading or causing the other. And this might seem intuitive, but it's kind of good to see evidence of this. It's really the amount of what you're taking. Both alcohol and marijuana can be contributing to this, at least in terms of the development of substance use disorder. Now, what about neuropharmacology? While alcohol is messy, there is no specific alcohol receptor. It does interact with a number of different receptors and produces widespread effects in the brain. Now, as we heard earlier in the day, THC is different. It does bind to cannabinoid receptors, and we know that its interaction with CB1 receptors is the main sort of mechanism which causes the psychotropic effects of the drug. Now, CB1 receptors are the major G protein coupled receptor in the brain. That's shown by PET imaging here. Pretty much anywhere you look, which one of these am I using? This one. Pretty much anywhere you look in the brain, you'll find a CB1 receptor. Some distinctions in the relative density of the receptors. But again, very widespread effects throughout the brain. Now, if you look at the pharmacology of effects produced by alcohol and THC, you see that they produce very similar effects in terms of the neurotransmitters we know are involved in motivation and reward. We hear a lot about dopamine and drugs of abuse, and it is true that alcohol and THC do increase dopamine in the mesostriatal system. Now, the effects on dopamine are less pronounced than for other drugs of abuse, like psychostimulants. But both alcohol and THC increase opioid peptides, and this effect contributes in a major way to their motivational effects. And they perturb serotonin and inhibitory and excitatory amino acids in acetylcholine. And collectively, this contributes to the motivational and positive reinforcing effects of these drugs. And you can see that the direction of change is in general the same for alcohol and THC. So that would suggest with their combined use, the likelihood is it's going to be an additive at least effect in enhancing these reward-related neurochemicals. Now we know that THC interaction with CB1 receptors produces its psychotropic effects. If you block that with a CB1 antagonist, you reduce cannabinoid self-administration, cannabinoid reward, the increase in dopamine by cannabinoids. Makes total sense from a pharmacology standpoint. What's interesting is the same pattern emerges for alcohol. If you genetically delete CB1 receptors or block them pharmacologically, again, you reduce alcohol intake, you reduce the rewarding effects, and you reduce alcohol-induced increases in dopamine. Conversely, if you administer a CB1 agonist, activate the receptors, you increase alcohol intake and the motivation to receive alcohol. So that suggests that CB1 receptors at least play some role in the motivational effects of alcohol. There's also evidence that disruptions in endocannabinoid signaling contribute not only to problematic marijuana use, but also problematic alcohol use. This is a really busy slide, so I'll just very briefly show you what the main points here are. These are polymorphisms that are associated with the CNR1 gene that expresses CB1 receptors. They are associated with increased use and dependence on marijuana, but they're also associated with more severe forms of alcoholism, increased impulsivity, comorbid alcohol and cannabis dependence. Polymorphisms in the gene encoding Pha. Pha is the enzyme that clears anandamide from the brain and periphery. Some of these genotypes are associated with increased marijuana craving and withdrawal, but also with risky drinking behaviors in humans and possibly an increase in binge-like drinking. So collectively, these studies suggest the endocannabinoid system may be playing a role not only in marijuana reward and use, but also alcohol. And that leads to the question of, well, does alcohol alter endocannabinoid levels in the brain? And it turns out it does. We've looked at this in my lab, and others have as well. I'll show you some data from the nucleus accumbens, which is a major hub in the reward circuit mediating the rewarding effects of most drugs of abuse. So these are anandamide levels. The animals are drinking alcohol during this orange symbol here. You see that drinking really doesn't do much to anandamide, but we do see pretty robust increases in 2-AG levels. And the rise and fall of 2-AG actually mirrors pretty well the rise and fall of blood alcohol concentrations. And it's a dose-dependent effect. Drink more alcohol, get more 2-AG response. Now, we also see changes in endocannabinoids with other drugs of abuse. Opiates tend to increase anandamide and suppress 2-AG. Nicotine increases both anandamide and 2-AG. Psychostimulants don't produce as much of a robust change in interstitial endocannabinoids, even though we know endocannabinoids do modulate their behavioral effects. But overall, this suggests that, yeah, drugs of abuse can alter endocannabinoid levels in the brain, and in particular for alcohol, this appears to play a role in their motivational effects. So these are all things that are related to the positive reinforcement associated with both alcohol and THC. Increased dopamine, opioid peptides, CB1 receptor signaling. We know that long-term exposure to these drugs decreases this positive reinforcement. And this is associated with a blunting of these effects, so diminished dopaminergic function, diminished enkephalin release, opioid peptides that interact with mu and delta receptors, and a recruitment of dynorphin release, which interacts with kappa receptors, which, among other things, can also suppress dopaminergic function. So these are things associated with a diminishment of positive reinforcing effects. There's also a reduction in CB1 receptor availability. We've heard about this already. This is PET imaging in humans, heavy cannabis users, in contrast with controls. Area in yellow are areas with diminished CB1 receptor availability. And if you can see it, this sort of tells you the brain regions that are affected across the brain. This is expected and well known. What's interesting is alcohol-dependent patients present a very similar deficit in CB1 receptor availability. In fact, even with a very similar sort of regional distribution, in some cases more pronounced effects, but we need more studies to figure out the relativity here. Now, the interesting thing is, if individuals stop using either drug for a period of time, CB1 receptor availability comes back toward normal, indicating this is an adaptation resulting from the long-term presence of either cannabis or alcohol. So these are things that are decreased associated with diminished positive reinforcement. We also know that an emergence of negative reinforcement mechanisms is critical for the development of addiction. And by negative reinforcement, I mean instead of a desire to take the drug for some positive effect, the motivation is more to take a drug to avoid some negative effect of not taking the drug. And of course, this is related to some forms of withdrawal things. The mechanisms contributing to this negative reinforcement are persistent, so they stick around after drug use ceases. And this can contribute to anxiety and depression and stress sensitivity, things that are sort of motivating factors to return to drug use, because if you start using again, these abate. Well, we know that negative reinforcement is mediated not only from the blunting of these positive reinforcement mechanisms, dopamine, opioid peptides, etc., but also the recruitment of pro-stress signaling mechanisms. Increased corticotropin releasing factor is a major point. Increased levels of CRF are evident in the amygdala, both during cannabinoid withdrawal as well as alcohol withdrawal. And the primary evidence for this is shown here. This is in rats, microdialysis data in the central nucleus of the amygdala. Over here, this is precipitated cannabinoid withdrawal, so an antagonist precipitated withdrawal. We see an increase in CRF levels. I'd like to draw your attention to the alcohol withdrawal. This is a spontaneous effect. CRF levels go up starting about 6 to 8 hours into withdrawal and peak at about 10 to 12 hours into withdrawal. And we know that this increase in CRF signaling plays a prominent role in excessive alcohol consumption, because if you block CRF receptors in the central amygdala, you don't change drinking by non-dependent animals. They happily continue drinking as ever. But you can dose-dependently reduce this excessive drinking by the alcohol-dependent subjects. Now, this increase in CRF also drives anxiety-like behavior. This is data from the elevated plus maze. The details aren't terribly important, except that the size of these bars reflects an animal's willingness to go out into sort of an open, exposed area. And animals like these dependent animals here that aren't spending as much time out there are thought to be more anxious. Well, you can block that anxiety-like behavior if you block CRF signaling in the amygdala. So these are factors contributing to factors or facets of alcohol dependence. What does this have to do with endocannabinoids? Well, we know that stress increases HPA axis function, leading to increased cortisol, ACTH, anxiety, and with long enough exposure, depression. We also know that stress increases or at least alters endocannabinoid levels in the brain. In particular, increases in 2-AG formation in the amygdala and the frontal cortex. And we'll hear more about this tomorrow. I'm sure Dr. Hillard will be talking about this, but But we know that this stress-induced increase in 2-AG serves to terminate stress responses. It's sort of a homeostatic feedback response to diminish stress responsivity. Well, we found that in alcohol-dependent animals, there is a blunting of 2-AG levels in the central amygdala. Data from non-dependent animals are in yellow, data in red are from the dependent animals. To the left of this dashed line here is while animals were still drinking alcohol. And so even though they're not in withdrawal, they have lower levels of 2-AG. Put them into acute withdrawal and the 2-AG levels decline even further, coming on about 4 to 6 hours into withdrawal and progressing further. And these are very persistent deficits in 2-AG. If you look a week, 2 weeks out later, there is some amelioration from these acute withdrawal effects, but there's still significant deficits in 2-AG. And it's kind of a double whammy because we know that CB1 receptor expression and function is blunted in the central amygdala during alcohol dependence as well. And we know that this stress-induced recruitment of 2-AG that I was telling you about is also blunted. So normally, a restraint stress elicits a big increase in 2-AG in the amygdala. This is a feedback mechanism terminating the stress response. The ethanol-dependent animals don't mount that response. So the 2-AG response to stress seems to be sort of blunted. Now, if we sort of ameliorate that or fix it by giving a 2-AG clearance inhibitor, allowing 2-AG to accumulate, we don't alter alcohol intake in non-dependent animals, but again, we reduce this intake by the alcohol-dependent subjects. And we can also reverse the anxiety-like behavior that's associated with alcohol withdrawal. So, this suggests that dysregulated endocannabinoid signaling participates in some facets of alcohol dependence. Now, we know that marijuana use can blunt CB1 receptor function and influence, and accordingly, combined use of marijuana with alcohol may hasten or exacerbate this facet of alcohol dependence. This might be one mechanism through which the combined use of alcohol and marijuana leads to some of these problems that we're seeing. Now, there are a number of other things that are dysregulated with chronic alcohol and marijuana use. One thing is that everything we know about this at this juncture largely comes from studies on each drug individually. We know very little about the combined exposure to these drugs at the same time in terms of additivity, synergy, or possibly even regressive effects. And so that's an area that we need to spend a bit more time looking at. So I'm told I've used up my time here, so I will summarize what we know, or at least what I've talked about this afternoon. We know that compared with either drug independently, concurrent marijuana and alcohol use increases the odds of developing binge drinking, substance use disorders and dependence, especially that of alcohol, major depressive disorder, and poor academic and professional performance that I didn't dwell on too much. We also know that when comorbid, this is not something I talked about, but when they're comorbid, cannabis use disorder and alcohol use disorder develop in concert. So they come on at about the same time. They follow a very similar trajectory over time, sort of suggesting that one doesn't lead to another, but they're joined at the hip as they go along. With one exception, there is some fairly strong evidence that suggests that early age cannabis use disorder is a very big risk factor for adult alcohol use disorders. It doesn't go the other way around. Alcohol use disorder at a young age doesn't seem to impact later cannabis use disorder development. But those are temporally distinct. When they're temporally related together, the idea of a gateway hypothesis doesn't seem to be very strong in the literature right now. Cannabinoids and alcohol produce similar pharmacologic effects and similar neuroadaptations following extended exposure, and accordingly their combined use might produce additive effects. And we know that endocannabinoids play a role in the motivational effects of alcohol, and dysregulation of this system is possibly involved in alcohol dependence. So marijuana use may exacerbate that. Now, what do we still need to know? There are plenty of things that we still need to know. For one, as I mentioned before, we don't know much about the actual combined exposure of the drugs in terms of pharmacology, so we need to have a look at that. We know that there's a strong genetic basis for alcohol use disorders and alcoholism, likely also so for cannabis use disorders, but we don't know whether there are different genetic susceptibilities for some of these polysubstance abuse problems. Age and again, genetics are particular issues that could come into play. Stress is a major factor. As I mentioned before, alcohol and cannabis are frequently used under stressful circumstances as sort of a self-medication. Well, we know that stress activation of the H.P.A axis and other responses alters the neural response to drugs of abuse. And so particularly with alcohol and marijuana and their combined use, the impact of stress on the neural consequences of the drug intake might be important, but we haven't really looked at that very carefully. Now, we don't know much about the strain of marijuana on these interactions. Certainly, strains of marijuana can differ in their THC content. Probably equally important is changes in phytocannabinoid content, in particular CBD. CBD, as we've mentioned earlier today, can minimize or antagonize some of the effects of THC. CBD can be anxiolytic, and it's neuroprotective. There is some evidence that CBD can protect against some neurotoxic effects of chronic alcohol exposure. Therefore, this might be an important factor, as well as the route of THC administration. And we need to know just a bit more about the comorbidity of these drugs in terms of therapeutic approaches. Is it a distinct entity or something that's an exaggeration or an amplification of each individual disorder independently? So with that, I'd like to thank my lab, past and present, collaborators, and absolutely NIH for their support of research in this area, both coming from the NIAAA and NIDA. Thank you.
While we're collecting the questions, I'll introduce myself. I'm David Goldman. I'm Chief of the Lab of Neurogenetics and Acting Clinical Director at NIAAA. So my job is to read the questions, and if any demonstrations break out, to manage those. And if that happens, I'll get into character with this hat. And I already had the first couple of questions, but actually before reading them, I'll say that this morning that we heard from Ben Kravitz and Ken Mackey and Daniel Piamelli, the neuroscience and neuropharmacology of cannabinoids, and then Lauren Parsons in this last talk really brilliantly tied together the neuropharmacology of cannabinoids with other drugs. And then in the first two talks of this session, we heard an extension then of these neuroscience effects of cannabinoids into the real world. And so we heard earlier today about cognitive effects, and then Edie showed us that they play a role in psychosis, and Alan did the unenviable task of showing that cannabinoids are addictive agents. So now I'll start reading questions. And the first question is, this is to Eden Evins. What thoughts do you have on there being no population-level increase in schizophrenia, although there is a population-level increase in cannabis use?
It's a great question, and I didn't have time to touch on that. So I think there's data from Australia that there's no increase in psychosis or schizophrenia, although there is increased use of cannabis, but not so much an increased use of high-potency cannabis use. And in London, though, there seems to be an increase in schizophrenia prevalence and a very high incidence of use of particularly high-potency cannabis. So I think the data are mixed in that regard. It's also going to take a long time to see the effects, or several years to see the effects in population levels of a doubling of a risk, if that's what the risk is. And I think that's a conservative estimate.
Right. That's a very good point, that we may be seeing an increase in psychosis with these high THC agents. So our next question is tweeted actually from Sargon, and it reads, do the statistics of treatment of cannabis addiction account for factors like court-ordered admissions? And so this might be to Alan, yes.
They do account for them. If you look at that same data set that I shared some information on, the TEDS data set, they do break it down by court-ordered, not really court-ordered, but court-referred judicial process type of things. And for adolescents, for example, it's about 50-50. For adults, it's about a little bit less than 50-50. But you see that actually with all substance use disorders. So the argument's usually that, cannabis folks are just forced into treatment. But people are forced into treatment for most substance use disorders.
So the next question is a mechanistic question which might also be for Eden, has any investigation been made into a tie between increasing concentration of endocannabinoids in adolescence and psychosis or schizophrenia? So have there been any biochemical measures or measures of Pha, the enzyme, or for that matter 2AG, to connect schizophrenia to cannabinoid use?
So I don't think I can answer that question. Yeah.
Because probably the data are not there.
Right.
But, I guess what would be needed would be perhaps CSF studies or even post-mortem studies, but they would tend to be at the end stage of the disease. We really wouldn't have what we might most want, which would be in at-risk children and in first episode schizophrenic patients.
You could do that with PET and CB1.
Yeah, it might be done with PET. Good point. So I have another one for Alan. Sorry, Lauren. And this one is, how do the economic cost of cannabis use disorders compare to other substance use disorders in terms of loss of productivity, et cetera?
Yeah, that's a great question. I don't have any hard numbers on that at all. Basically, I guess I'd answer it that we see the same type of consequences. We see the same problems with work, the work situation, the school situation. Obviously, drug driving on cannabis isn't quite as bad as drunk driving, but there's the impact there. So there's impact in all areas. I just don't know the economic numbers and whether we have good numbers in that area or not.
Thank you. So moving on quickly to Lauren Parsons. How does marijuana itself impact brain 2AG and anandamide levels? And this questionnaire, and I'm going to read the name of the questioner. It's Dr. Schroeder. Also asks, is this of the same magnitude as the alcohol effect, and are the effects synaptic? Or, no, I'm sorry, are the effects synergistic?
Excellent questions, and I'm again afraid I'm going to have to say I don't know. In fact, that's a major hole in the literature right now. Is I think there's been a presumption that while exogenous cannabinoids override the effects of endocannabinoids, so people haven't really looked at the endocannabinoids. So we don't really know what THC or other synthetic cannabinoids might do to the endocannabinoids. So really, unfortunately, at this point, there's not an answer to that. There is modest evidence in a microdialysis study for an acute, I believe, rise in anandamide with synthetic. It was a Win 55212 administration. Beyond that, we really don't know. But it's a very interesting question and something we should get to.
So we have a tweeted question here, I think a couple of them. And the first is, Dr. Parsons, what hypotheses do you have for why marijuana and alcohol are the most common drug combo? Is it more rewarding than alcohol plus other drugs?
Well, I don't know if I can comment about across the pharmacopoeia, but I do know that there are reports. A few studies have looked into this and tried to quantify it. And it is reported that the combined use of alcohol and marijuana does increase ratings of high, good drug effect and overall stoned. And there's sort of an interesting interaction there. Apparently marijuana sort of reduces the sedation or the drunkenness that comes from drinking alcohol and sort of emphasizes more the euphoria associated with the drug. Alcohol speeds the onset of the perceived high after smoking. And so their combination sort of makes each drug better, so to speak, and I think that might be a motivating factor. And they're of sort of similar effects. They're both anxiolytic, they're both relaxing, and I think people would use them in the same place. That's conjecture on my point. But as far as relative strength of reward compared to alcohol and cocaine combinations, for example, I don't think I can comment on that.
Alan?
Yeah, I think probably a simpler answer is that the availability and access to alcohol and cannabis are the highest. So I think they're easily available to everybody and probably result in more use of in combination. Probably alcohol, cocaine is a better combination, but not as available would be mine.
It's your preference. And if I could say too,
Yes,
that
Eden.
cannabis and tobacco, also both highly available, are also used together, maybe even more commonly than cannabis and alcohol. So I think availability is huge.
I guess it depends on who you hang out with. So so here is a question for Eden, and it's one I was wondering about. Given the risk effect of cannabis in psychosis, what would be the effect if the cannabis had higher levels of cannabidiol? Or could it even be antipsychotic?
Well, so the studies that show a doubling or more of risk of schizophrenia with cannabis use is with presumably cannabis that's roughly equal parts or equal proportions of cannabidiol and THC. There have been small studies with some promise of cannabidiol monotherapy or actually added to antipsychotic treatment with very modest effects. So I don't think we're ready to say it's therapeutic, but certainly low potency cannabis is what we have the initial data with, which seems to increase risk for psychosis, is that the low CBD, high THC increases that risk much more. Did I answer your question?
Yes. There are many questions coming in via Twitter. And I'm wondering if you could just make, or comments. We'll get them later. Okay. I'm trying to read all of these, and it's a little confusing. Is there more or less endogenous cannabinoid in the brain of a schizophrenic patient? So I'm afraid that this is a little bit of a repeat of the previous one. Why don't we just skip it? I'm sorry about that. The answer would be we don't know. This is for Dr. Parsons. Given the similar pharmacokinetics of ethanol and cannabis, to what extent is there a which is, I'm not sure if that's true, but given that it's similar pharmacokinetically, to what extent is there a substitution of these two substances versus co-administration, and what are the implications for public health? So I think that this questionnaire is asking about drug substitution.
Yeah, I agree with you. I'm not sure it's a pharmacokinetically based effect. But yes, there has been a lot of talk about the idea of these drugs possibly substituting for each other, and they have many characteristics that would suggest that. There is some data that supports that. At some of the dispensaries, there have been a few studies, particularly in the Bay Area, polling people more or less whether or not their alcohol use decreased when cannabis became available for their particular indication, and they all pretty universally said yes. There is sort of anecdotal data that at the age of 21, alcohol use goes up and cannabis use goes down, and people have cited that as evidence for substitution. So there's anecdotal evidence or even documented evidence here and there. I think one thing that sort of goes against that is what I was showing in terms of the simultaneous use of the drugs. If they substituted, there wouldn't be quite the same motivation to take them at the same time as there seems to be, and this seems to be unique for that drug combination. So it's possible, I suppose, in individuals who have reason to substitute, particularly for some form of self-medication. There may be fewer side effects associated with cannabis, and there might be a substitution going on there. Beyond that, I think there's not strong evidence for that.
Just a comment. There's a little bit of data in the clinical area, not great compelling data, but when we're treating cannabis use disorder and somebody is still using alcohol or has a history of alcohol use disorder, we're certainly concerned that it'll increase when they quit cannabis. And there's one laboratory study that I think Erica Peters and John Hughes did that showed a little bit of that. And in our clinic, we haven't been able to statistically show that it's there, but it's certainly something to be wary of.
So there are many good questions, but we only have time for one more. And then I think that there may be responses offline later. But for the last question, I wanted to take this question of Tom Arneson because it gets at a crucial issue of when cannabinoid drugs are used in treatment, for whether that there is risk of addiction. And so the question is, what would the addiction risk be for patients who are using medical cannabis extracts and extracts of different types? Is there any evidence that bears on what the risk might be with medical marijuana use?
Well, I think the risk factors to some degree will be the same risk factors for anybody that are posed. So if they're a person with low risk factors, like they have an advantaged environment, they have no history of drug use in their family, they have other things going on for them, they have a job, etc., probably going down that path is lower risk than somebody that's had problems in the past, has a mental disorder, etc. So all those same risk factors, I think, would apply.
I think what may have inspired this question is that with opioid use for chronic pain, that of course the person who is taking high amounts of these opioids becomes neuroadapted, but by and large they can be withdrawn, and they do not have an opioid use disorder. And so where these drugs are going to be used medically, do we think that in that sort of use that it won't be the problem of the recreational use?
I guess the same way that opioids, those folks not at high risk that get opioid medications prescribed that go on to be able to withdraw from them, you'll have the same thing with marijuana. Although it may be chronic, they'll develop some tolerance. We don't know a lot about treatment over time or duration. We'll learn that as we conduct those studies. But I would think with appropriate monitoring, et cetera, it'll be, if it's viable, it's viable, and the addiction would not be functionally severe if you have a person that is following the rules.
Well, I think time will tell. Thank you. Thank you very much, Alan, and the panel, and Wilson.